as I was saying, my name is Renee. I work with the Tobacco Prevention and Cessation Division in the Department of Health. And um, trauma is sort of my level of, it's sort of my interest. Um, we joined a community of practice with the National Council for Mental Wellbeing and went through a trauma and tobacco cohort this year. These are my coworkers that went through this with me, and we learned so much about how trauma impacts the use of tobacco and individuals who are dealing with, who are struggling with addiction to tobacco, and how that interplays with uh, previous traumas. Um, so let me gather my thoughts a bit here. I'm sort of taken aback by the issue that we had with technology. Usually I have three screens and now I just have one, so pardon me. So starting in with trauma-informed care, what is it? Why is it important to our work? And what are we doing about it? So trauma-informed care is essentially just looking at our patients, looking at the people that we're interacting with, and thinking in a different way, thinking and perhaps they're acting in a way that we consider to be irrational or some way that doesn't make sense to us. And perhaps they're presenting with symptoms that aren't playing well with others, or we're not understanding where exactly these people are coming from. So trauma-informed care essentially teaches us to look at those people with a different lens and to consider the fact that it's very possible that they're dealing with trauma, and trauma is a confounding factor. It confuses what we're actually looking at. It often presents in ways that don't make sense uh, in our treatment. Why is it important to our work? It's important to our work because we're handling people who have different backgrounds, they have different experiences, and the treatment for one person will vary from the treatment to the next. What are we doing about it? Well, we're just learning about it. We're learning how this interplays with people's lives and how this may impact the way that we respond to them whenever they present to us, ask us for help. Um, Frequently, people with trauma do not respond in the same way that anyone else would whenever you're offering help or offering suggestions. So it's good to have the information in our back pocket that perhaps the person that we're dealing with who isn't handling instruction very well, they may be they may have trauma in their background that is impacting the way that they respond. And let me know if you can see this video.
Over half of us have a chronic disorder such as high blood pressure or autoimmune disease. Rates of anxiety, depression, PTSD, and addiction are skyrocketing. Why? The roots of these issues and more can often be traced to trauma, adverse
Okay. Sorry.
childhood experiences, chronic stress, and ultimately, nervous system dysregulation. Meet your autonomic nervous system. Let's call it ANS. ANS takes care of a lot of your automatic functions, like your heartbeat, digestion, and body temperature. ANS also manages your survival and stress response, working to keep you alive when your life is in danger. ANS functions as our built-in detection system, constantly scanning our environment for cues of safety and cues of danger. As ANS scans the environment, it has three general responses or states. Safe. You feel calm, relaxed, and connected to those around you. Mobilized. When ANS detects danger, it sends a command and your heart rate and breathing increase, adrenaline and cortisol are released, and blood rushes to your muscles so you can handle the threat. This is our fight-flight response. Immobilized. When ANS detects that the danger is so great that you can't fight or run, it shuts you down. In this state, our heart rate, blood pressure, and body temperature decrease, and pain-numbing endorphins are released. ANS does all of this automatically without us thinking about it. ANS doesn't just use these states for survival. It uses them to navigate through the world each day. When ANS functions well, it moves fluidly from one state to another. 1 minute mobilized and ready for action, and the next resting and recovering. ANDS will often blend states together. When we play, ANDS combines the mobilized and safe states. And when we are intimate with loved ones, it combines immobilized and safe states. When ANDS can stay flexible and fluid like this, it helps us manage and become resilient to stress and negative events. We're able to bounce back and move on. Unfortunately, when we experience trauma and chronic stress, it can keep ANDS from functioning in a healthy, regulated, and resilient way, and can keep us stuck in states of survival. A friendly get-together can become frightening. A simple meeting at work can become threatening. For those with a history of trauma and chronic stress, the ANDS detection system often becomes faulty, constantly signaling danger even when we are safe. It's like ANDS is an alarm system, constantly signaling fire even when there's no smoke and no flames. Consistently living in these survival states can be debilitating, and we often develop adaptive strategies like using drugs, alcohol, food, work, or sex in an attempt to bring regulation and temporary relief. Understanding how trauma impacts us is critically important. There is a whole spectrum of experiences that can be traumatizing and adversely impact ANDS, like accidents, assaults, and natural disasters, which are often called shock traumas. There is also developmental or relational trauma, when we experience chronic adversity, abuse, neglect, and lack of safety while growing up. Many other experiences can be traumatizing, including chronic stress, medical procedures, and adverse community environments like poverty, discrimination, and violence. Additionally, new research in epigenetics shows us that trauma can get passed down genetically at least 3 generations. In the past, we've thought about trauma as events that happen to us. We now know that trauma is an experience, not an event. It's what happens inside of us as a result of what happens to us. It's our response to the event rather than the event itself. Over 20 years ago, Kaiser and the CDC launched a groundbreaking study of over 17,000 patients that showed a direct link between adverse childhood experiences, or ACEs, and long-term health and wellness. In the study, 2/3 of participants reported at least one ACE. Over 20% reported 3 or more. When participants reported 4 or more ACEs, this corresponded to an increased chance for heart disease, cancer, drug abuse, and more. With 6 or more ACEs, life expectancy decreases by almost 20 years. We are learning that many physical and emotional symptoms may emerge from a chronically dysregulated ANDS. When ANDS gets stuck in survival states, our biology shifts its focus from the tasks that keep us healthy, happy, and thriving to surviving the immediate perceived threat. Many conditions and symptoms that are chronic and difficult to diagnose and treat can be attributed to a dysfunctional ANDS. Our childhood experiences can also keep us from connecting with others. This is vitally important because as children, our #1 survival priority is to attach to caregivers. When the people responsible for our safety aren't safe, and we are living in chronic states of unsafety, ANDS doesn't get wired right. The part of ANDS that judges what is safe and what is not becomes faulty. If intimacy and connection were unsafe as a child, as adults we'll often unconsciously reject attempts from friends and partners to connect. Even though intimacy and connection is what we want, ANDS feels it's unsafe and won't allow it. Trauma compromises our ability to engage with others, replacing the need for connection with the need for protection. When there has been trauma, ANDS can no longer differentiate between our unsafe past and our now safe present. ANDS can't turn off the need to protect, even though we are now safe. So what can we do when ANDS becomes dysregulated? How do we recover from trauma and develop a healthy, regulated, resilient nervous system? Fortunately, we can retrain ANDS to feel safe again. This is best done with the help of others. Each one of us has an ANDS, and our ANDS is constantly communicating with and attuning to the states of others. We autonomically mirror the states of those around us. This is called co-regulating. We see it in herd behavior. If one animal senses danger, the entire group becomes more alert, increasing their chances of survival. We're exactly the same. When we're with others who are stressed, angry, or depressed, it makes us feel worse. When we're with others who are calm and happy, it makes us feel better. Connecting with others who are safe, attuned, and present is the best way to restore a healthy ANS. For those struggling to recover from the impacts of trauma, there is an emerging field of innovative clinical therapies that have been developed to reestablish safety and regulation to ANS. We're also learning that many of the activities we intuitively know make us feel better, like spending time in nature, practicing yoga, dancing, helping others, and more, can help ANS become more regulated and resilient. Healing from trauma and finding release from being stuck living in survival states comes as ANS becomes regulated, increases its capacity for resilience, and regains its flexibility. It's not about being calm all the time or mobilized all the time. It's about having a flexible and resilient nervous system that can accurately assess safety and danger and responds appropriately. We're truly resilient when we can fluidly move from one state to another. For those living with the impacts of trauma and chronic stress, becoming unstuck is like beginning a new life. For the rest of us, understanding how our nervous system states guide our behavior can help us become happier, healthier, and more empathetic human beings. Collectively, we have an epidemic of social issues that are rooted in trauma. If we can do the work to heal past traumas and build healthy, regulated nervous systems as individuals, families, and communities, we can end the cycles that continue to reinforce our greatest challenges and create a safer, vibrant, and more connected world.
So I love that video because it really breaks it down, gives it to us in an easy to understand way. Um, as you can see here on this, there are so many effects that trauma can have on individuals. Their um, it's not just about their responses to us as providers or as friends and family members. It actually, makes a huge amount of impact on their lives. So these things are important to note whenever we're handling patients or individuals who need help with cessation or their physical ailments. Any number of these things can present, and it's important to just keep an eye on these issues and know that it's very possible that trauma is causing some of these issues, and creating a safe space for these people really impacts the way that they can heal over time. Excuse me. So the message that I'm bringing to you today, I hope um, out of this you can understand that essentially you and I, as individuals, just with putting on the lens of understanding trauma and understanding the impact that it has on people, we can have more patience with people who have trauma. I want you to be encouraged in your work and understand that the work that you're doing is great. Uh, just because you're not having success with a certain group of people, that doesn't mean that the work is less valuable or that it's not effective. I want you to take away from this today, if you would, that trauma does impact people. It does affect the way that they respond to others. It does impact the way that they are able to interact with healthcare providers and anyone who is attempting to give them help. They have less trust in people, less ability to connect with others, and it will be harder to make an impact on them because we have to gain their trust first prior to being able to actually walk them through the process of, for example, cessation or whatever it is that you're interested in helping them with. So this just shows that the ACEs, if there are, um, as the ACEs increase, the likelihood of people smoking, it increases as the number of ACEs increase. Um, you'll see that as you're dealing with individuals that essentially dose response relationship increases just based on their exposure to the ACEs. Let's see. So what does trauma have to do specifically with smoking, and how do we address it? So of course my interest is in smoking. I'm not sure exactly what everyone's interest is in, but it has to do with any addiction, any healthcare, any health situation. Trauma impacts it directly, because ACEs cause health risk behaviors. As they mentioned in the video, people become willing to, or they feel that they need to do additional things to self-soothe, whether that's through seeking out drugs and alcohol, smoking, additional sexual exploits. People feel that they need to self-soothe, and that harms them over the long term. So all of these traumas affect them in a variety of different forms. It's not just around tobacco, but rather it can be through any number of health conditions. It does impact them long term in their health outcomes. Uh, so any kind of household dysfunction, abuse, all of those things create the need to self-medicate because they're just trying to avoid the feeling that that has caused inside of them. So a lot of people who have trauma will attempt to put a Band-Aid on or just get a little bit of relief from the way that they're feeling inside. And we know that whenever people are seeking alcohol and drugs, and tobacco, frequently they're just asking for something to soothe them from the way that they're feeling inside for just a moment. People who have ACEs, some of those long-term health consequences, it has been shown, this study shows that individuals with a history of severe trauma are twice as likely to develop a smoking dependence. 45% of adults with PTSD smoke, and 73% of those who smoke, they smoke more than one pack of cigarettes a day. That's a significant risk to their long-term health. So essentially, we as people in the community and providers, whenever we're adopting a trauma-informed approach, we're going to try to bring in a strengths-based framework that is one that we're approaching them with understanding, we're approaching them with empathy, and also we're giving ourselves empathy and grace and understand that the work that we're doing, as I said before, the work that we're doing is good, process that we're doing is good. It's good for us to keep in mind that some of the people that we're reaching out to are dealing with trauma or they have trauma in their past. It's going to take a little longer. It's going to take different attempts so that we can reach them and help them out, even though we're attempting nothing more than to help them. It just takes a little bit longer to earn their trust, takes a little bit longer to get them to where they're ready to move forward. So if we give ourselves a little bit of grace and understand that we as people who are trying to help them, we're doing good work. It just may take a little extra time with people who are dealing with trauma. Part of the success, part of the way to help people succeed, people who are dealing with trauma, is to give them additional control or additional empowerment. So if you have a plan that you usually have for cessation and you're saying to them, here's X, Y, and Z that you need to do with someone who's dealing with trauma, if they're not able to or willing to follow those steps or they have frequent setbacks, you may try adding in the option or opportunity for them to make choices about their treatment. And that will give them a little sense of control, a little sense of empowerment, and they tend to respond better to those approaches. So as we're learning about trauma, it's important to just have a paradigm shift so that we're involving this trauma lens into whenever we're looking at people that we're working with. Just keep in mind that there are common connections between substance use and trauma. So if somebody's coming in, they are constantly returning to their use of whatever substance, just keep in mind that that may be a trauma response. The trauma may need to be addressed prior to them being able to quit whatever substance it is that they prefer. Um, And just recognize and understand that people can respond in all different ways whenever they're dealing with trauma. They may act out, they may withdraw, they may be responding to you in refusing to continue to seek services. People act in all different ways, but if it's a little different from the norm, you may just consider that it's possible that they're dealing with trauma that's unaddressed, and that may need to be healed before they can move forward in whatever help you're trying to offer them. One of the things that's really important for us to learn as we're looking at this trauma-informed care is that we as providers or helpers need to remember that it's important for us to reduce re-traumatization. So one of those potential re-traumatizations is if we have rules in place for our clinic, for example, where if someone misses 2 appointments, then they're discontinued from services, that could be a re-traumatization, um, because, perhaps the person is dealing with uh, whatever trauma at home. And then if we discontinue services for them when they were just starting to trust us, then that will cause them to have re-traumatization. They'll consider the provider to be less trustworthy. And then when they're seeking out services, if they seek out services again, they're going to have less trust in that provider and less willingness to adhere to any medical advice. So there's also a genetic factor that comes along with this. As they mentioned in the video, there's heritability that comes along with addictions and trauma that can be passed down through a few generations. So there's a heritability for as you see, behavioral health conditions. It's between 40 and 70%. So we're looking at those questions where we're saying, do you have anyone in your family who has these type of addictions or has this type of mental health issue, behavioral health issue? There is a heritability factor that we need to keep in mind. We also need to remember that as for nicotine receptors, those are also affected by heritable um, factors, those genetic factors. And then whenever you also consider that heritable possibility, also keep in mind that if they have that and then they also have ACEs in their own life, then that may be a compounding factor of why they're having such difficulty dealing with cessation or, treatment of whatever the condition is that you're working with. There's also the consideration that there's a difference between the sexes and how they respond to ACEs. Women have a higher prevalence of ACEs, particularly with sexual abuse. Um, their exposure is going to be different. Their responses are going to be different. Um, so as you're handling people who have different experiences, just keep in mind that that work is going to be different based on who you are working with. Those experiences are going to be different based on who you're working with. And just bear in mind that this work is going to be a little harder. It's going to be a little more challenging to reach out to people who have these ACEs, people who have trauma in their history. It's going to be harder to earn their trust. It will be harder for them to accept services, but it is possible to help them. Whenever we're trauma informed, we just also need to recognize that people who have trauma in their histories, or they have a behavioral health condition, they actually want to quit at the same rate as the general population. So keep that in mind that individuals who are dealing with that, they're still hoping to quit whatever substance, they're still wanting to quit at the same rate as everyone else is, but it's more challenging for them. It's harder for them. So if we're looking at it like that, we need to understand that we're framing smoking as a coping mechanism and that they're putting a little band-aid on what's happening inside of themselves. So it will be challenging to get the help to them that they need, but just bearing in mind that this is not like you need to stop smoking. It's rather looking at this as they're doing this as a coping mechanism. They're putting a little band-aid on some kind of pain that's happening inside of them. So we also need to look at this through the lens of giving alternative adaptations that are more empowering to them, giving them solutions that can help self-soothe, but are not damaging their health long term. And you all are very creative and ingenious. I look forward to listening to the ways that you've come up with to help people with that exact step. So we also need to eliminate punishment because, as I mentioned earlier, re-traumatization is a very real thing. And if we're punishing those people who have finally trusted us with a bit of the information about themselves and who are trusting us with some of their medical care or some of their assistance with cessation or et cetera, um, if they have a relapse, it's important to not punish. It's important to accept them and understand that that pain must have gotten bad enough, or there must have been a trigger that caused them to relapse. And we need to continue to support them and show them that we're a safe person, and we're a safe organization that they can rely on to give support for them to help them with their long-term health. This is a very text-heavy slide, and I apologize for that. I took it directly from the National Behavioral Health Network. But I do keep it because I think it's really good information. So whenever we're looking at things with this strengths-based intervention process, we need to remind ourselves that recovery is possible. If you treat the trauma, then you may see symptom reduction. I don't expect you to be a trauma-informed, or rather a trauma support. I don't expect you to be someone who's treating that trauma. However, if you're handling someone or helping someone who has trauma, it's important to understand that the treatment of the trauma is a very important part of this process. So if they're not receiving treatment for the trauma, it's very unlikely, or it may be unlikely that they're going to have any symptom reduction, such as reducing use of substance, etc. So we need to, if it's possible, to get them to trust us enough to refer them to evidence-based interventions, then that's a really good step. Um, as long as they're asking us for help, it's wonderful if we can present to them that we're a safe space and that we have trustworthy referrals for them so that they can get help for that trauma. Whenever we're looking at motivational interviewing, there are places that you can get trauma-informed motivational interviewing, and that can help with harm reduction. So, as I mentioned before, this is if we're reducing that re-traumatization, then we have the option to go through the trauma-informed motivational interviewing process and help them out with uh, our normal processes, but with just a little spin on it to keep in mind that they may need additional wording or different wording than the general public. So that if we're offering cessations services, the cessation practice should incorporate a trauma-informed care values. We need to always emphasize safety and continue to impress upon them that smoking is never safe. It's never a safe way to put a Band-Aid on. There's no shame in it. There's no coercion that needs to happen. It's simply, this is hurting you and we don't want you to hurt any more than you already did. So let's help you replace this little Band-Aid that you're using with something that's a little more, that's better for your long-term health. And then we as providers or as people who are assisting with their health, we just need to continue to build our trustworthiness. Part of that is not shaming them and not re-traumatizing by punishing in any way. Maximize their choice and control. So if if you have a process that you typically go through, make sure that they have choices, make sure that they can opt between one or two things or give you their, feedback as to what they think might work for them. That really assists with the process whenever you're handling someone who has or helping someone who has trauma. Be collaborative with them. They're the one who knows what they've been through. They're the one who knows, they're the expert on their own self. So keep that in mind whenever you're helping them out. So whenever you're looking at if we're looking at this from an organization standpoint, whenever you're dealing with helping your organization to reform their opinions and their work around trauma-informed care. These are the 4 R's. We have realization, recognition, response, and resisting re-traumatization. So realization is essentially just understanding how the trauma can affect individuals, families, groups, organizations, communities, and frankly, your organization may be dealing with trauma in and of itself. A lot of organizations went through some traumatization whenever COVID-19 happened, for example, or whenever there's been any kind of natural disaster. So you may take a look at your own organization, take a look at your own employees, and see if you're dealing with that in your organization or within your work group as well. So you can also recognize the signs of trauma through screening, through supervision practices, and you can help out by offering employee assistance programs. A response is applying the principles of the trauma-informed approach to all areas of functioning in organizations, such as your policies, procedures, staffing, and organizational culture. Part of that is resisting the re-traumatization, just understanding how policies and practices can impact people who have trauma and affect them in negative ways that that go against what we're actually trying to do. So individuals who have mental health and substance use challenges are affected significantly by tobacco use and by tobacco promotion. 1 in 4 adults have some form of mental health substance use challenge. And as you can see the statistics here, I won't read specifically to you, but these substances are aggressively targeting those individuals. And almost 40% of all of out of those people, almost 40% of all the cigarettes smoked are smoked by people who have mental health challenges. So it's important to keep that in mind, that these people this is a disparity. Let's see, that's pretty text heavy. I'm going to move on. So 2 of the important tenets of the trauma-informed resilience oriented approach is just changing our mindset, understanding that, again, the work that you do is important, it's valuable, and it is a really good process, a really good work. However, whenever we're dealing with people who have trauma, it's going to be harder, it's going to take a little longer, things are going to be a little more challenging, but it's worth it in the end because these individuals do want to quit, they do want help, they just don't trust as easily. So let's change our mindset. If we're going to be trauma informed, let's change our mindset from what's wrong with you, why can you not quit smoking, you know it's bad for you. Instead, let's change our mindset to what happened to you. And we do not need to be the mental health provider, we do not need to be the counselor, but just simply shifting our mindset and thinking to ourselves, what happened to you, can give us a little more patience, a little more empathy, and can help us to build trust and safety along with this person. And let's just assume that everybody is doing the best that they can. And so if anyone has any questions, I'm happy to answer.
And we had a chat. Any resources for suggestions for trauma-informed motivational interviewing?
Yes, actually, the National Council for Mental Wellbeing is a wonderful resource, and they have cohorts that that start up, I think, twice a year. But if you go onto their website, the National Council for Mental Wellbeing, they have a lot of resources available to you. Those are that's some of the best. Excuse me. That's some of the best work that's being done right now. They're doing work. It's out of Colorado, and several of their. Thank you, Kathy. Many of their webinars are available online, and they have research articles as well. I think they have some motivational interviewing resources. I've also worked with a group called CCMI, and as a subsection of motivational interviewing, they have behavioral activation or brief activation planning. That's also a really valuable way to help people who have trauma. So you might look into that as well. It's a very quick intervention. It's supposed to be 5 minutes or less. It uses the spirit of motivational interviewing, but they have a specific algorithm essentially that you go through to help the individual to create their own plan for whatever health goal it is that they have. I find that that's been very valuable for the work that people are doing around cessation or around working with the individual who has trauma, because the individual who is seeking treatment actually is creating their own plan. So that's through CCMI. Yes, thank you, Kathy. And Kathy dropped in the chat the Rethink Indiana, Rethink Tobacco Indiana. They have a lot of wonderful resources on their website as well. And they do tobacco treatment specialist trainings. They also offer a brief training that's a 6-hour training. So if you are not interested in going through the full process of becoming a TTS and sitting for the test, they do offer a 6-hour training that is a condensed version that doesn't have like you don't become certified, but you do gain the information about how to help.
Okay, well,
Anything
Renee,
else?
thank you so much. Such a ton of great information in there. Um,
Sure.
yeah, we've got one more comment there from a tobacco treatment specialist, and just agreeing with their talking about your ACEs and how that impacts what it's like to try and
Yes,
quit smoking.
I
So
really appreciate that comment, Skip. I think that's really important that it's a lot of people are really, they're pretty harsh on people who are smoking, but if you're not looking at it through a trauma-informed lens, um, like I wasn't, previously, it's easy to say something along the lines of just, you need to quit smoking, it's bad for you. But if you're looking at it through a trauma-informed lens, it gives you more information about, oh, there are other things that are impacting that. So I appreciate that comment, Skip, and I'm glad for you.
absolutely. Well, thank you everybody so much for attending today. Again, thank you, Renee, for bringing this
Sure.
topic to us and giving us your time. And again, the recording will be up on our YouTube channel in the next week or so. We hope that you will check that out, check out our other content. Feel free to share, post. We love it when people help spread the word. So thank you all and have a
Absolutely.
good afternoon.
Thank you.